Hello everyone, this is Dr. Sandeep Madaan, your anatomy faculty. So in today's video, we are going to discuss certain important questions from neuroanatomy. For each question, I'll give you 45 seconds to solve, and after that, I'll give you the explanation of the concept. Okay, so let us now start. So this is question number 1. So what is your answer? Here the correct answer is epidural space. Why? Because this patient was involved in the accident and the CT reveals that middle meningeal artery has ruptured but the meninges remain intact. So the collection of the blood is outside the dura, and anyway we know the middle meningeal artery rupture is the most common cause for the epidural bleed, right? So this is how you can see how the epidural bleed will be seen and how the subdural will be seen. So here let me zoom in to show you. Epidural bleed, you will observe that meninges are intact, but the blood is collected outside the meninges part and outside the dura part specifically. And here you will be getting the collection, correct? On this side you can see it is the subdural bleed. Now one more thing that you should remember, that extradural bleed or the epidural bleed will be of arterial type and the middle meningeal artery is the most common cause. Whereas for the subdural hematoma, subdural hemorrhage, we have the bridging veins most common cause, that is the venous bleed is the reason here. Okay, now let us go to the another question. Just before that, let me summarize. Extradural hemorrhage, we have the anterior division of the middle meningeal artery, that is the most common vessel involved. Subdural hemorrhage, we have the bridging veins. Subarachnoid hemorrhage, there will be rupture of the berry aneurysm, and the subarachnoid hemorrhage, usually the history given is the thunderclap headache or the worst headache of life. Okay, and for the cerebral bleed, if the question is on the cerebral bleeding, cerebral hemorrhage, then which artery will you think of? That is the Charcot artery. Okay, what is the Charcot artery? It is the branch of middle cerebral artery. Okay, so these are the most common vessels involved in these different conditions. Now we are done with this concept. Let us move on to the second one. Now what have you marked? So which of these nuclei will be connected to the cerebrum via the thalamus? See, we are looking at right now, that is the cortex of the cerebellum, and inside we have the white matter core. This is the cortex part and this is the white matter core. Within the white matter core we can further see the nuclei. These are called as deep nuclei, deep cerebellar nuclei. And to remember their names, like these are their names, we can use the mnemonic: doctors eat good food. D for doctors, D for dentate, eat is emboliform, good is globose, and food is the fastigial. So that is our mnemonic, and these are the name of nuclei. Now the fastigial nucleus is by and large having the connections with the vestibular nucleus and the emboliform and the globose. Together they are called as nucleus interpositus, having the connection up to the spinal cord level. Whereas the dentate nucleus is connected to the cerebrum via the thalamus. So you must have heard of dentato-thalamic tract, dentato-rubrothalamic tract. They will be reaching the thalamus, and then like in the ventrolateral part of the thalamus, and then the thalamus will project these fibers to the cerebrum. As a thalamic radiation it will go, and it will be reaching the area number 4 and the area number 6. Okay, next question. Now very simple type of question. Now asthma attack, what will you do? You will give either beta agonist or muscarinic inhibitor antagonist. So here the question is, it will be inhibited by, you want to inhibit the parasympathetic, because you will give the sympathomimetic and parasympathetolytic. Okay, so that is why B will be the answer over here. Now moving on to the next concept. Yes, what are you thinking, guys? Here answer will be corticospinal fibers. Let me explain. So the given question history is the weakness of the limbs is there, right? So basically we are looking at the motor deficit part. But the choice A and choice C, they are the part of ascending tract. Anterolateral system is the name given for the spinothalamic tract, which are carrying the pain, touch and temperature. Medial lemniscus, choice C, is a part of dorsal column tract, and the dorsal column is concerned with the fine type of sensation. Okay, so anterolateral is nothing but the spinothalamic tract, which is concerned with the pain, touch and temperature. Okay, pain, touch, temperature, crude type of sensation, whereas medial lemniscus is a part of dorsal column, and the dorsal column, it carries the fine type of sensation. And here we are marking B choice because B will lead to the like motor deficit will be there. But what about the choice D, rubrospinal? It is a part of extrapyramidal system. Okay, but individual involvement of rubrospinal tract will not give this typical presentation where we see the weakness of one side like upper and the lower limb. That is a characteristic feature for the pyramidal tract. That's why choice B will be the answer. Now moving on to the next question, dear friends. Now this question is dealing with the gallstone colic. Okay, what is your answer? So the correct answer is B. Why? See that this is a patient where the patient is experiencing the colicky pain, right, from the gallbladder stone. What is happening? The pain is actually caused by the spasm of the smooth muscles in the wall of gallbladder and also the distension of the bile ducts. That will be the reason. But why the smooth muscles are so many, like they are doing the contractions at a very frequent basis? The choice D explains that. These violent contractions are actually attempt to expel the gallstones, because these are kind of causing the obstruction, so they want to expel. So that's why they are trying their level best to expel the gallstones. And the referred pain will be seen in the right upper quadrant, the hypochondrium or the epigastrium, which is the recognized site for the cholecystitis or the gallbladder stones, these type of features. But choice B, why it is wrong then? We know that sympathetic fibers, okay, the sympathetic fibers to all the viscera, they will travel with the blood vessels. So whatever blood vessels are going, when they branch out, the sympathetic will be also branching out. They will be reaching the viscera using the sympathetic fibers. The pain fiber will not be actually carried by the sympathetic. Listen to this part carefully, because sympathetic and parasympathetic are essentially motor system. So pain is not carried by them, but the pain fibers, they travel with these fibers. They are separate system, but for our exam point of view, we can consider the pain fibers will be carried along the sympathetic system, but sympathetic is not carrying them as such. Anyway, to keep it simple, what is the blood vessel supplying over there in the gallbladder part? That is the cystic artery, which is a branch of hepatic artery, eventually coming from celiac trunk, not coming from supramesenteric artery. So the celiac trunk branches will be giving the sympathetic fibers will be spread. So that is why it will not come from the superior mesenteric plexus. That was the catch. Okay. Now moving on to the next question. Yes, what is your answer, dear friends? Here, the question, like basically, we can reach the answer by doing the, ruling out the options. Because we know the skin is having the glands, right? Sebaceous glands are there, sweat glands are there. Those are exocrine type of glands are there because they are having the ducts, okay? So if there is a burn of the, like skin is burned in any part, so there will be exocrine gland secretions will be definitely impaired. So answer will be D here. But why not others? Because skin is not producing any trophic hormone, although it produces vitamin D and all, but it does not produce trophic hormone as such, so that will not be affected. Anyway, it is not being produced by the skin. And similarly, it does not have any efferent fibers like GSE fibers or GVE fibers will be also, they have nothing to do with the skin nerve supply. So that is why by ruling out, we can reach the answer. Moving on to the next concept. Yes, what have you marked? So here we have certain marking given in the picture, and let me zoom in to show you what is this. Here we can see this is the part where we have the corpus callosum, and here you can see the two ventricles. These are the two lateral ventricles, correct? Between the two lateral ventricles we have one medial wall, that is septum pellucidum, and below the septum pellucidum this round structure is the fornix. Okay, so what has been marked over here is the fornix. Okay, now the question says that the fornix is coming from what structure, that which of the following will be projecting the efferent fibers, right? So answer to this question will be hippocampus, because hippocampus efferent fibers are nothing but the fornix, and where they are going, they will be reaching the mammillary body. Let me explain this way. We have this one circuit is there which is called as Papez circuit, and to understand this Papez circuit, we can remember one mnemonic that is called as Hippomase. Hippomase is the mnemonic, and you can see how to use this from the hippocampus. This is the hippocampus over here. From the hippocampus, this is the efferent coming as fornix, that will be reaching the M for mammillary body. From the mammillary body, it will be going to the anterior nucleus of the thalamus. Can you see it's near my thalamus? So this A is the anterior nucleus of thalamus. From the anterior nucleus of thalamus, it will move on to the cingulate gyrus. Here you can see we have the cingulate gyrus. Here we can see this is the cingulate gyrus over here. Okay, that is the cingulate gyrus. From the cingulate gyrus, it will go to the entorhinal cortex, and from the entorhinal cortex, it will be again sent. The fibers will be connected to the hippocampus. So what is happening? Hippomase is the mnemonic. Hippocampus sending the fibers fornix, reaching the mammillary body, then anterior nucleus of thalamus, the cingulate gyrus, and then the entorhinal cortex. But what is the role of Papez circuit? This is concerned with the emotions and the consolidation of the recent memory. Sometimes what might happen that during the accident, the hippocampus goes into the shock. Now when you examine the patient will be having the remote memory intact. Patient will be having the recent memory also intact. But surrounding the accident, when the hippocampus was in shock, the patient is unable to recollect that memory because that was never consolidated. Okay. So that was the concept. Now moving on to the next one. Now in this case, answer will be conduction aphasia. Why so? See, let me explain this with the help of this picture. We have the Wernicke's area. This area is for the understanding or the comprehension of the speech. When we understand someone else's speech, it is because of the Wernicke's area. And this is the Broca's area. This is for the production of our own speech. Whatever we are expressing, whatever we are producing the speech, that is because of the Broca's area. So Wernicke's area is for the understanding, Broca's area is for the production, and they are connected by the arcuate fasciculus. Suppose Wernicke's area is affected, then what will happen? Patient will not have any understanding, but patient can speak because Broca's area is intact. Then this patient will be keep on speaking, but his sentences are not comprehensible. Okay. If you compare this particular case with another case where the Broca's aphasia has taken place, in case of Broca's aphasia, the patient's understanding is intact because Wernicke's is intact, but the Broca area is gone. That's why patient can't speak, patient can't produce the speech, or patient can't express. And because his understanding is intact, patient knows that something is wrong, because of that he is not able to speak. So that makes him frustrated also. But now coming to this particular given picture, in this particular given question, what was given that the patient is having the repetition which is poor. That means patient can't repeat after you, but otherwise patient's comprehension is intact, fluency is intact, articulation is intact. If comprehension, fluency and articulation is not affected, in that case these Wernicke's area and the Broca's area are alright. But the patient's only problem is repetition is poor, that is he is not able to repeat after you. That's why we'll go with the conduction aphasia. But one very important point here, when you read this line repetition is poor, that immediately should not mark conduction aphasia. Because suppose a patient of Wernicke's aphasia comes to you. Now he is not understanding your commands, your anything, whatever you tell him. and he's speaking, but when you ask him to repeat after you, obviously he will not be able to repeat. So even in case of Wernicke's aphasia, repetition will be poor. But now we know the reason, because of the not understanding, that's why he is not repeating, because the reason is there. Okay. For the Broca's aphasia, patient can't express, patient can't speak. When he can't even speak, then obviously he will not be able to repeat after you. So even in case of Broca's aphasia, there is no question of repetition. But the point is, here we know the reason why he is not repeating. But if everything else is okay with the patient, he can understand, he can speak, everything fine, still he can't repeat after you, repetition is poor, then you will label this as conduction aphasia. Now, dear friends, moving on to the next question. Yes, now dear friends, what is your answer? Answer is pretty obvious here, thalamus. Why? Because given history clearly says that the patient is having the loss of sensation in complete one half of the body and the same half of the face. Okay, so one complete half including the face, the body is not having any sensation, but at the same time muscle strength is 5 by 5. That means we are looking at the sensory stroke. That means all the sensory fibers which are supposed to pass via the thalamus. Okay, so there must be a thalamic stroke. So all thalamic stroke, particularly the posterior part where the sensory fibers are relaying, that part is affected, and that is why this patient is having only the loss of sensation, but there is no motor loss. Now dear friends, moving on to the next question. Hanji, what do you think? So straightforward, because the patient is having this person is like suprarenal medulla is hypersecreting, and we know the medulla itself behaves as kind of ganglion. So preganglionic fibers must have come, and then with response to that the medulla is secreting. So who is overstimulated is the preganglionic sympathetic fibers are overstimulated. Let me show you one diagram, that here we can say the preganglionic fibers will be reaching the ganglia. If the preganglionic fibers are stimulated, then the ganglia will also further become stimulated, it will secrete. So we have the preganglionic, parasympathetic, we have the sympathetic and all, but adrenal itself, it will act as the ganglia. So preganglionic sympathetic fibers will be reaching over here. With response to that, the adrenal will secrete these hormones, the epinephrine, norepinephrine. All right, now moving on to the next question. Yes, what is the answer? Here the correct answer is B. Now why so? See, look at this part. C is the insula over here. That is the insula. Okay. Why it is called as insula? Insula literal meaning is the like island. Okay. Island is just like the land, but it is separated from the main mass. In a similar manner, this C is a cortex, but it is separated from the rest of the cerebral cortex because it lies deep. Now, what is D here? That is, you can say this is putamen. This one here, the globus pallidus, and this is the thalamus. The A is the caudate nucleus, and what is B is the internal capsule. Now we know these features which are given, that is because of the motor weakness, increased muscle tone, that is representing the upper motor neuron lesions. And upper motor neuron, it like what is upper motor neuron is the corticospinal fibers, okay, pyramidal tract fibers. So we know among these B is the justified answer because B is the internal capsule, which is actually having both ascending and descending fibers in it. Okay, so those descending fibers, that upper motor neuron will be affected over here. That is why it has led to the features given in the patient. Okay, otherwise A is the caudate nucleus and this D is the putamen, and along with the globus pallidus they belong to the basal nuclei. Okay, so now we move on to the next question. Now, before telling the answer, what is your diagnosis? So here we can say the dizziness is given and the nystagmus is given. It is because of the vestibular nucleus involvement. Okay, and the loss of pain and temperature on the right side of the face, whereas left side of the body. Okay, so it is because why the right side of the face? Because right sided trigeminal nerve is affected, but left side of the body, that means we can say the spinal lemniscus is affected. So spinal lemniscus is gone and the spinal nucleus of the trigeminal is gone. That's why this is happening. Ataxia, intention tremor, it is because of the involvement of the cerebellum, inferior cerebellar peduncle, and in addition she is hoarse. That means the laryngeal involvement is there. Laryngeal involvement tells us that is nucleus ambiguous is involved. Nucleus ambiguous is involved. Okay, there is a pupillary constriction and drooping of the eyelid. That means, and the face is drier. So ptosis, meiosis, anhidrosis, these are all features of which that is Horner syndrome. So Horner syndrome, nucleus ambiguous involvement, and right side of the face sensation loss, whereas the left side of the body sensation loss, and also the vestibular nucleus involvement. So all these features taken together, we can say this is the right lateral medullary syndrome. That is the right lateral medullary syndrome. So this point that we have to write here about the direction, which sided lateral medullary syndrome. Why it is important? Because if you see, we have two choices which are very close, because A choice is for the right lateral medullary syndrome, but B choice is for left sided lateral medullary syndrome. So here answer will be A, because we have discussed that it is the right sided syndrome. What about C choice? Now C choice can be involved if the given syndrome is lateral pontine, not the lateral medullary. Okay, now let us look at the diagram. This is the medulla, where we can see these are important structures which are present in the lateral aspect and then in the medial aspect. So if there is lateral aspect of the medulla undergoing infarction, what will happen? Lateral medullary syndrome. If this part is undergoing infarction, that will lead to the medial medullary syndrome. Let us move on to the next question now. This image is given, okay, and related to this image, this question is given. So we have read these choices, but again let me show you the picture. So what is A over here? A is the insular cortex, and that is what was given in the choice. B is the biggest release center. Who is B? B is the thalamus part. B is the thalamus. So thalamus is the biggest release center. That is true. A is the insular cortex. That is true. We have discussed the thalamus, biggest release center. What about C choice? C is the, if you look at this part, C is what? C is the, it looks paler, isn't it? This C, it looks paler. It is nothing but the globus pallidus. Okay, and we know the afferent unit will be this complete unit. What is this? Is the chordator nucleus. This one is the putamen. Together they are the afferent unit, but the globus pallidus will be efferent unit. And what about D? D is the you can say internal capsule, particularly posterior limb of the internal capsule. But what is the choice over here? That D has the combination of sensory and motor fibers. Yes, that is true, because it is internal capsule and it is having the combination of both. Okay, so what is A? Is the insula. A is insula, and B is the thalamus, that we have understood. Obviously this is the biggest release center. C is the globus pallidus, which will be the efferent unit, not the afferent unit. Okay, and D will be the internal capsule, especially the posterior limb of it, right? Now we have understood C will be the correct answer. Let us move on to the next question. Anji, what have you marked? So here the patient is having persistent food seeking behavior and he is obese, and mother is saying he is having the sometime aggressive and bizarre behavior. The patient is having persistent food seeking behavior. That means his center of satiety is not working. So which nucleus of the hypothalamus will work as the satiety center? That will be ventromedial, because lateral nucleus will stimulation will lead to the eating, but the ventromedial nucleus stimulation will lead to the satiety. The patient is having the lesion in the ventromedial, that's why that will be the answer. But we have different nuclei in the hypothalamus. Let me give you certain tricks to remember these nuclei. Okay, so here we can say this, we have one of the nucleus, that is anterior nucleus. Anterior nucleus, we will use this mnemonic AC. We know AC does the cooling, so anterior will do the cooling. If anterior does the cooling, what is the role of the posterior nucleus? Posterior will do the heating. Posterior will do the heating. And the lateral nucleus is for eating. Lateral is for eating, and the medial will be for satiety. Okay, ventral, the medial will be for the satiety. For the medial, we will write here ventromedial. Now, how will remember this? Now, anterior, posterior, we have learned AC. Okay, anterior, we have AC, so anterior does the cooling, right? That is the mnemonic. So, posterior will be doing the heating. For the lateral, we can remember two ways. One way of remembering is that if we eat more, then we will spread laterally. Okay, so that is one of the way to remember. But if we don't eat anything, if the satiety is there, then we come back to the medial. But the other way to remember is, if the lateral is having any lesion, then what will happen? L for lateral, L for lean. The patient will become lean. But the ventromedial is having any lesion, then the satiety will not happen, and the patient will keep on eating, and the patient will become very massive. So these are the tricks that we can remember. We can use to remember the nuclei functions. Also, we can remember one more mnemonic, that is SAD POX. What is that? S is the supraoptic nucleus. This supraoptic nucleus, it makes ADH hormone, and P is the paraventricular nucleus. paraventricular nucleus will make the oxytocin. So these two hormones, that is ADH and oxytocin, are released from the posterior pituitary, but they are made by the nuclei of the hypothalamus. So thank you so much everyone. I hope you understood and you enjoyed learning these concepts. My best wishes. Thank you so much.